Hi, this is Mark Sederberg. I'm currently a fellow at the University of Utah in their sports medicine department. I previously completed a residency in PM&R at the University of Washington. Today I'm going to speak briefly on some common shoulder conditions that are seen in adaptive athletes. We'll also touch on basic anatomy of the shoulder just to provide some context in talking about these shoulder conditions. As an introduction, there's many types of athletes that have a propensity to injure their shoulders. There's some notable examples up here. Rafael Nadal, the tennis player in the top left, was held out of the Paris Masters in 2010 due to a shoulder injury. Felix Hernandez in the middle, the pitcher for the Seattle Mariners, had a shoulder strain and landed him on the injured list in 2019. Michael Phelps on the bottom left injured his shoulder while training for the Rio Olympics, was at about 75% according to him, and therefore came home with a disappointing 5 gold medals and 1 silver medal. But today we'd like to talk about the adaptive athletes, which we see here on the top right, individuals participating in a wheelchair basketball tournament in Seattle, who also are using their shoulders not just during their sport, but to get around during the daytime in a wheelchair, and are also at high risk for shoulder injuries. So why should we care about shoulder health? It's probably fairly obvious, but shoulder pain is very common in those that use their shoulder a lot, be it pitchers, tennis players, or para-athletes. Those that use wheelchairs, whether or not they are participating in sports, tend to have a higher rate of shoulder pain. It's been estimated to be as high as 76%. And it does seem to increase with the amount of time the person is in a wheelchair. Most importantly, shoulder pain can really limit participation in athletic activities, and with time it can interfere with activities of daily living, such as getting around and transferring to and from a chair. There's some evidence that proper care of the shoulder can help prevent injuries. And once they do come, which they are so prone to do, there's many ways to treat and successfully remove the pain from the shoulder. So we'll go over a little bit of just some shoulder anatomy to understand some of the injuries that are common. So the shoulder is a relatively large ball on a small socket. Mobility and proper movement of all 3 bones in the shoulder are needed for a proper shoulder range of motion. The 3 bones are the arm bone or the humerus, the shoulder blade or the scapula, and the clavicle or the collarbone. The scapula is important for keeping the ball in the ideal location in the socket. And there's 17 muscles that either attach to the scapula or pull it in different ways, so it's not uncommon to have muscular imbalances that put it in a less ideal position to perform its task. The stability of the shoulder joint has been compared to a golf ball on a golf tee. In other words, it's not very stable. If you compare it to another joint like the knee joint, which is seen here on the left, it has a lot of bony contact and very strong restrictive ligaments. Therefore, it's only really able to move in one plane of movement. However, the shoulder is the most mobile joint in the body, and if it were not so, our arm would not be nearly as useful. But we do sacrifice some stability due to its lack of bony contact. So with muscle groups that attach to the shoulder, there's the large muscles. These are the ones that everybody likes to work out. We have the pectoralis major here on the chest, the deltoids on the shoulder, and moving into the back, the trapezius, which spans up into the neck and down here into the mid-back, along with the lats, or the latissimus dorsi. All these muscles are very important for powerful movements. The smaller muscles, which you don't find people working out as often in the gym, but are very important to muscle and to shoulder health, are rotator cuff muscles. So we have here on the back of the shoulder the supraspinatus, the infraspinatus, the teres minor, and underneath the scapula you have the subscapularis. These are very important and are often impaired in many shoulder conditions and are the target of rehab frequently in many shoulder conditions. I want to briefly talk about scapular motion. The scapula are responsible for about 1/3 of shoulder abduction, or moving the arms away from the body. Their movement helps keep the scapula in the best position to keep the arm ball in the socket. So if the scapula is impaired or there are muscular imbalances, it can contribute to many of the shoulder pains that we'll talk about today. No pain, no gain is something that hopefully is kind of going away, but 10, 15 years ago, that was the mantra of sports. Shoulder pain is not normal or expected, even if it is common. It's important to know that playing through pain can sometimes mean longer recovery or more damage to the shoulder. You should see a sports medicine doctor, physiatrist, or your primary care doctor to determine the proper treatment and the cause of your shoulder pain, rather than trying to just play through this. As a disclosure, there are numerous causes of shoulder pain. This lecture is really just designed to be informational. If you want an accurate diagnosis and treatment plan, you should see your physician rather than just trying to self-diagnose. So the most common cause of shoulder pain is called shoulder impingement syndrome. This consists of about 30 to 35% of shoulder pains that are seen in the clinic. What this entails is compression of soft tissue structures between bones with overhead movement. As you see here, the supraspinatus, one of the rotator cuff muscles, comes out of this rather narrow bony canal. And in impingement, when the arm is abducted or brought away from the body, it's brought into contact here with bursa and consequently here with a hard bony roof. It can be very painful. With time, this can also irritate and enlarge the tendon, which in turn makes the impingement worse. It's often brought on by repetitive motion, especially overhead motion. Usually if you go to the doctor's office and you have a pretty clear picture, this can be diagnosed without x-rays or other imaging. The good news with this is it typically responds very well to physical therapy, which focuses on special exercises to strengthen the rotator cuff muscles, which helps bring the head of the humerus downwards and more into the socket, rather than riding upwards and grinding up here on the top of the shoulder joint. Steroid injections can be helpful for pain control in selected cases, but do not treat the underlying cause. Another common shoulder condition is a rotator cuff tear. These can be grouped into chronic or degenerative tears, which are very common with aging and increasing age. They may or may not be painful and often are incidental findings on MRIs or ultrasounds, or acute tears, which tend to occur during overhead activities or a fall on that arm. These can present with shoulder pain, weakness, especially in a full thickness tear, and in chronic cases there can be atrophy or muscle bulk loss seen as well. This is often diagnosed with ultrasound or MRI, though occasionally there can be physical exam findings indicative of a complete thickness tear. These treatments range depending on the severity of the tear and the chronicity, from physical therapy to injections, and in certain cases surgery can also be helpful. Adhesive capsulitis is another fairly common shoulder ailment. This is caused by inflammation to a shoulder capsule, which leads to thickening and stiffness. In a healthy shoulder, there is a lot of redundant capsule tissue, as we see here on the left. It wraps around the shoulder joint, and it allows for the shoulder to move in a large range of motion without restricting movement. When it does become inflamed, this can kind of scar down here, and the shoulder is not able to move very well because this capsule prevents a large range of motion. This is fairly more common in those with diabetes, thyroid disease, or after a stroke, though this can happen in just about anyone. This can also happen with prolonged immobilization. Initially, this can be quite painful. Later, it leads to prolonged loss of motion, and then it can take a while for a return to function and return of range of motion. The timeline can be up to 18 months from start to finish. You may need an x-ray just to rule out other conditions, such as an occult fracture. Injections are often a way to alleviate pain, especially in the painful beginnings of this. It's likely that it does not shorten the course, however. And once you are done with the painful part of the adhesive capsulitis or frozen shoulder, gentle stretching with physical therapy is indicated and can help speed return of range of motion. Another cause of shoulder pain is due to acromioclavicular or AC joint pain. This is seen here on the top outside part of your shoulder. It's a very common site of early arthritis. This is not uncommon to see on x-ray in people in their 30s, even though it's not always symptomatic. And those that use wheelchairs more frequently have arthritis in this joint. Additionally, it can become irritated with excessive loading, and then it's not uncommon to sprain this with a fall directly onto the shoulder. It's often seen with football players, but it can be seen in any individual that has a fall directly onto the side of their shoulder. If you do have this, you should have pain over the AC joint, and you should have pain that increases with cross body, so moving your arm across your body, or with overhead activities. Often this can be diagnosed just with a physical exam, but it's not uncommon to get an x-ray to really appreciate any arthritic changes in the joint, or ultrasound could be used as well. Treatments for this include physical therapy to assist with posture assistance, an injection to calm down inflammation and pain. If those treatments are not successful, there are surgical options for treatment as well. So let's say you do have some shoulder pain, but nobody likes going to the doctor. Even doctors don't like going to the doctor. So hopefully we can remove some of the unknown as far as what to expect if you do go. If you arrive when you meet with your physician, they'll have a lot of questions about your pain that are not bad to have ready, such as when the pain started, where it's at, activities or positions that make it better or worse, and what sort of treatments you've tried. They may also have a lot of questions about what sports you're playing and what sort of equipment you're using. An examination will likely need an exposed shoulder, so you can wear appropriate clothing that can expose the shoulder, or they'll have you change into a gown. They may or may not order imaging depending on if it's needed in that situation. And then they'll have a discussion for what sort of treatments are available for you. This may be simple, such as activity modification or physical therapy. They could offer some medications like anti-inflammatories or an injection if it's indicated. Surgery typically isn't recommended initially, but if you have not done well with other treatments, you may have a referral to a surgeon. During a pandemic, it's brought a lot of angst and fear going to the doctor. Things can look a little bit different right now. So a visit, either initially or a follow-up visit, might be performed over video chat. If that's the case, you might try to perform physical exam maneuvers described and demonstrated by your physician. Or on follow-up, they might be able to review X-ray or MRI results with you, or chat about your progress on PT over the phone. If you do end up having a physical visit, masks are typically required by both clinicians, staff, and patients, and symptom screening is typically done at the door. You may want to ask about who may accompany you to your visit, as rules will vary depending on which office you're going to. And then there should be physical distancing that is done when possible, such as in the waiting room and while chatting with the physician, but not actually receiving a physical examination. As far as treatments, the big difference here is that some physical therapy can be done virtually. While it is helpful for them to have a visit initially to check your range of motion, strength, and weaknesses, many of the follow-up appointments and exercise teaching can be done virtually from home. If you do end up with a physical therapist for one of these shoulder conditions, here are some things that you can expect. They should have goals to increase range of motion by stretching tight tissues and then strengthening weak tissues, which are often rotator cuff muscles and their tendons. They often will also focus on strengthening your scapular stabilizing muscles. The goal is to keep you active and participating in sport without shoulder pain and damage. If you have healthy shoulders currently and you want to prevent shoulder ailments in the future, it's likely that a shoulder maintenance program will be helpful. This has been proven with baseball pitchers and soccer goalies with dedicated shoulder maintenance programs. So be sure to catch some of the other videos that we've made regarding a shoulder maintenance program designed for para-athletes and wheelchair users that might have similar benefits for you. That concludes my presentation on common shoulder conditions in adaptive athletes. I hope it was both enjoyable and informational for you as well. Thank you and keep moving.